Dr. Kin is a colorectal surgeon and an associate professor of surgery at Stanford University. She completed her general surgery residency at Stanford and her colorectal fellowship at the Cleveland Clinic in Ohio. She's also board certified by the American Board of Lifestyle Medicine. Her clinical practice includes management of colorectal malignancies, IBD, diverticular disease, and benign anorectal conditions. Her research focuses on prehabilitation, perioperative optimization, and improving short and long-term health for surgical patients through health behavior changes. She also serves as the Director of Wellbeing for the Stanford Department of Surgery, and we're very excited to have her here tonight.
Thank you. Thank you for having me. So today I'm going to talk about non-J pouches and continent ileostomies. No disclosures. So here is a case of a young person with medically refractory UC, had a total colectomy, is now ready for completion proctectomy and an ileal pouch. So the question is, should we do a J, an S, or a W? So obviously, most cases are done with a J pouch. And as you know, there's sort of this out of these three, the J pouch is the simplest one to do, but there are some circumstances where an S pouch and less commonly a W pouch would be helpful. So one of the, looking at this diagram, you can see that an S and a W pouch they use more bowel, and they also are hand sewn. So that definitely adds to the time that it takes to do these procedures. And that may be, sort of a non-starter for some cases. I'm going to go over, some outcomes. So in terms of outcomes, there is no difference in adverse events after J versus S versus W pouches. So anastomotic leak, anastomotic strictures, wound infections, pelvic sepsis, SBO, pouchitis, and pouch failure are all pretty much the same when comparing these three constructions. And for functional outcomes, there are some differences. So there's no difference in symptoms of daytime seepage, nighttime pad use, urgency, incontinence, or perineal excoriation. For the J pouch, compared to the S and W pouch, there's an increased stool frequency and increased use of antidiarrheal medications. And compared to the W pouch, there's an increased use of daytime pads. And then for the S pouch, there's an increased risk of needing to intubate the pouch. It's more of an emptying issue. And you can see why when you look at the outlet of the S pouch, like this part of the bowel can be a little on the longer side. And so for that reason, it can be difficult to empty. And so they might need to use a rectal tube to assist in emptying. That can be mitigated by shortening this segment between, the end of the pouch and the anus. And so the reason why it might be helpful to do an S versus a J is that sometimes the mesentery just lends itself better to an S pouch. So like the length of the mesentery, it may just work out better to do an S pouch. So still, given that, it's still pretty rare, and it really just needs to be in the right circumstance and the right patient. So that sort of wraps up the sort of non-J pouch portion. So I'm going to spend most of the time talking about continent ileostomy. So just an overall view of, for example, a K pouch, a Coke pouch. So it would be, proctoclectomy or like a colectomy followed by a completion proctectomy, and then creation of a pouch using some limbs of the terminal ileum, creating the continence mechanism, and then it is a skin level stoma that someone would intubate. So here's another schematic where you see like the reservoir here, the ileum coming in, and then a skin level stoma with a tube that someone would use to catheterize a few times a day. So I'm going to go over some indications of a continent ileostomy. So usually it's ulcerative colitis or FAP, someone who's had a total proctocolectomy, who is not a candidate for an ileal pouch, or had a failed ileal pouch, or has an ileostomy, an endoleostomy, but doesn't want it anymore for some reason, whether it's quality of life or prolapse. I had a patient who had just like this constant prolapse, like down to his thigh, of the ileostomy, and was considering a continent ileostomy, and it actually worked out really well for him because a pouch like that is not going to prolapse. I do not do it. So this is me personally. I do not do it for someone who's trying to avoid a colostomy. So this is not that it can't be done or should never be done. But for me personally, just, looking at the risks of continent ileostomy, I don't do it for someone who has a functional colon and say had an APR for some reason and just doesn't want a colostomy. I wouldn't take out their whole colon and then make like a continent ileostomy. I am very wary of doing it for someone who had colonic inertia, had a total colectomy for it because of the risk of a small bowel, sort of pseudo obstruction or motility issues, which can then, make it very difficult to figure out what's going on if someone has a continent ileostomy on top of that. Some people will do it for Crohn's disease. I've seen it described, but it is pretty risky, just as it is, risky to do an ileal pouch, a pelvic pouch in someone with Crohn's disease. But in select patients who are very motivated and understand the risks and have never ever had small bowel disease, it can be done, but I personally would not. And then, people who have an ileostomy, say, and they have already dehydration issues and nutritional issues, I wouldn't do a continent ileostomy because of the amount of bowel that it uses up. It's just going to exacerbate those problems. So a big part of deciding whether or not to go forward with a continent ileostomy is weighing these like major risks and potential benefits. So there is a very high complication risk, which we'll go over, a very high revision rate. So, that half of patients at some point will need a revision. The, undergoing a major operation for quality of life purposes, that is always something that's a little bit, it can be really controversial. Also, the risk of, if a patient has a continent ileostomy, they need to realize that very few MDs or healthcare providers understand it. So if they live in an area where they're far from their surgeon or a surgeon who understands it or anyone who understands it, then it can be dangerous. We've had, I've had patients who, for example, got into like a car wreck and then ended up in the unit and, were not able to intubate their stoma and like didn't intubate, no one intubated it for, days, and that can be a really big problem. And also because ostomies are less and less common, supplies are getting harder and harder to get. So patients understand that risk and they're realistic about it. They're committed, they're reliable, meaning that they're not going to not intubate. So they're going to, be reliable about intubating every few hours. They're healthy and they can sustain a major operation. They have a body habitus that supports the sort of actual configuration of the pouch, and someone who could, we could safely use 60 centimeters of small bowel, then it's something that can be safely considered. So here's some do's and don'ts. So in terms of setting expectations, it's really important to sort of lay out all the different things that could go wrong and for patients to understand, what the process is going to be like. It's a big operation. They're in the hospital, for more days than they are for like a standard colectomy. They have a tube indwelling for a while the pouch sort of heals. And they need to know about all those, potential complications and revisions. It's important to, again, assess the functional bowel that they have by assessing, how much lomotil or Imodium they're taking, how watery is their output, how often do they get dehydrated, and also really looking at their actual bowel length. And a lot of that really goes back to looking at their prior operations and figuring out, how much bowel may have been lost in the past, say if they had like a failed J pouch and it got excised. Also ensuring that they are reliable and that they are healthy and robust enough to sustain a major operation. The don'ts are I would not make a continent ileostomy at the same time as the total proctoclectomy. I think, a lot of patients are like, devastated by the idea of needing a total proctoclectomy and living with an ileostomy. And I think it's important for them to live with a standard ileostomy, to see what it's like and see what they can handle. Because a lot of people will come around to it and be totally fine with it and really, not want to have the continent ileostomy after all. And they realize they can live quite a normal life with an ileostomy. I wouldn't do it unless patients are at least close to an ideal body weight, and we'll talk about why. And I never guarantee that it will work perfectly or even be possible. I always say I will try my best. I think it's doable, but there may be incontinence, there may be a valve slippage. And I think it's really important to be on the same page with the patients on what our expectations are. So let's go through the Coke pouch in particular, the construction of the K pouch. So again, it involves quite a bit of small bowel. So it's essentially an S pouch and then plus. So I use between 10 and 15 centimeter length times 3 for the S, and then a 12 centimeter segment to make the valve, and then about 7 centimeters or so to form the outlet between the pouch and the skin. So I usually put a couple sort of outer layer of sutures. We make this long enterotomy along the 3 limbs, and then sew the sort of inner layer together. So now you have like a bowl, and then this is the formation of the valve. So essentially, you're creating an obstruction by intussuscepting a pretty long segment of intestine. This should not say 6 millimeters, 6 centimeters. So as you know, intussusception can causes an obstruction. So that's essentially what we're creating. And so it involves basically putting a Babcock into the end of the bowel and getting up to 6 centimeters, and then pulling it down and essentially getting it into the pouch. So there are a couple ways that this valve mechanism is the main cause for complications, meaning like needing revision. So the bowel does not like being intussuscepted. It is not a natural configuration, right? So the bowel is always trying to like unintussuscept itself over time. And even you'll see how we staple it. It's pretty intense, but somehow it can still unintussuscept. So the things that we do to try to keep it intussuscepted are a couple. One is that you can sort of scar up the serosa of the bowel. So over here, once you finish doing the back wall of the pouch, you can sort of scar up the serosa. Also, we will defat the mesentery. So you take the mesentery here in this 12 centimeters that creates the valve, and sort of take off the peritoneal layer, and kind of that helps it be a little stickier. And those are some efforts to try to make the valve stick. And then the other challenge also is that if they have a fattier mesentery, then it can be very, very hard or even impossible to do this intussusception. So that's why for patients who are a little overweight, if their mesentery is thick, then it can make it almost impossible. So in some cases where the mesentery is a little thick and you can't make this intussusception happen, then it can help to defat the bowel. The main risk, of course, is that, defat the mesentery. But the main risk there is that it may compromise the blood supply if you get into it. So this is the crucial part of making the valve. It looks when you do this and you make the intussusception, it looks terrible. I mean, it looks like it's dead. It looks like red, like congested. It doesn't look good, but that's sort of how it's supposed to look. And then this is a pretty intense stabilization process, but this is necessary. So then we use a linear non-cutting stapler to staple these 2 stapler loads. And essentially it's 2 stapler loads on either side of the mesentery. So the mesentery is actually here. And that helps a lot to staple it, to stabilize the valve. One of the big issues is that they don't make the stapler anymore. So all these types of staplers have a pin. So the disposable T-line staplers, right, transverse linear staplers have a pin to stabilize the staple loads coming down. If you don't have the pin, they'll scissor. So what we used to use was the sort of reusable stainless steel, like pretty strong stapler that didn't need a pin. So this has been one of the challenges I faced, which is trying to find a stapler that works. And there used to be GIA staplers that didn't cut, that we used to use for perioperative exclusion, which no one ever does anymore. So those have become extinct. And then also some like endo GIA staplers that we had to source from other hospitals that didn't have blades, but they're becoming more and more difficult to procure. So I've had to sort of hand sew with a permanent suture these staple lines when I haven't been able to find an adequate stapler. So that's actually a major issue. And then after you put these two staple lines in, then you close the anterior wall of the pouch until you're sort of at the level of the end of the valve. And then you put another stapler load essentially, through the valve and on the anterior wall of the pouch overlying your suture line. So that stabilizes the valve to the pouch wall itself. Okay. And then you close so then you can see here the cross section of what it looks like. So the mesentery again is here. And then after that, you close the front wall of the pouch. And then we put these sort of we call them fundoplication stitches, but we put these in to, again, stabilize the pouch to the valve or the outlet. And then there's a large amount of testing that happens. So I'll show you the Waters tube in the next couple slides, but you put the intubation tube that would normally be used into the pouch. You test it, meaning you put a bunch of saline into the pouch, you pull the tube out and make sure that it doesn't leak. Then you put the catheter back in and make sure that it drains properly. So you do that a bunch of times. Then you place it into the abdomen and then secure it to the abdominal wall. You make essentially a stoma defect and then test it again to make sure that now putting it through the abdominal wall hasn't caused some issue with the ability to intubate. You want it to be a straight shot. You want patients to be able to just stick the tube straight in and get into the pouch without any issue. So you test it a bunch of times and make sure that it's still continent and that it can be intubated easily. And this diagram actually has the stoma coming out at sort of a standard ileostomy location. Depending on the patient's body habitus, if they're, relatively thin and they don't have a lot of subcutaneous fat in the lower abdominal area, then I actually put the stoma much lower. So sort of, well below where you'd normally put an ileostomy, a standard ileostomy. And then, so we leave the catheter in and suture it in place. Usually our stoma nurses will go by later and create some elaborate taping mechanism to, get these stitches out so they're not so uncomfortable and sort of, keep that taped in for a few weeks. So here is another schematic of a slightly different type of continent ileostomy. So again, there's the continence mechanism, which is the valve, the intussusception, but this has an added feature. So again, this is not S pouch, this is like a U pouch, but what it does is that it has this, we call it a living collar. So this kind of wraps around. So it's like an added continence mechanism. So if you imagine as the pouch fills, then this little collar fills and creates like a little sphincter situation to add a little extra continence. So this is just another option. It does require like a little extra suture line here because you have to bring the upstream small bowel into a separate place in the pouch. So that is a BCIR that you may, encounter one of these days. So this is the Medina catheter that most of our patients use. Some use something called a Waters tube, but since it's like a 30 French Medina catheter, some come straight, some come curved. It has a couple big holes on the side and then one hole at the end. And that's what they use to intubate. And then most patients use something like this, like it's called an AM patch. But a pretty absorbent kind of Band-Aid that they just wear over the stoma. And again, it's a skin level stoma, so it doesn't need to be budded or everted the way that we do for standard ileostomy. After surgery, the tube stays in. It gets irrigated, every couple hours, and then when their bowel function returns, then you can start seeing the output go into the Foley bag. So it's a little awkward that so let me go back to this tube. So it's a little awkward because this is taped in and it's sort of sticking straight out sometimes. And then we attach it to a Foley bag. So it's just like a lot. They're sort of handling a lot, but it's just something they have to just cope with for the first few weeks. And then once they have bowel function, then you just continue, let them eat, sort of standard sort of return of bowel function type pathway that you would do. And then once they're ready to go home, then what they need to do before they go home is learn how to irrigate their catheter a few times a day, and also as needed. Like if they feel like their pouch is filling or they haven't had much output, maybe the tube is clogged, so they need to learn how to irrigate. And for the first, between 2, 3, 4 weeks, the catheter stays in with that irrigation. Then after that first period, then they can take the catheter out and catheterize every 2 to 3 hours when they're awake. But then at night, they have a constant drainage to like their Foley bag, or they commit to waking up every 3 to 4 hours to empty it. And we tell them not to eat or drink within 2 hours of bedtime. And then after that, they can go to every 3 to 4 hours during waking hours. Certainly catheterize the first thing in the morning and at bedtime, and then they don't have to catheterize at night unless they feel like their pouch is full. And then of course, before they leave the hospital, we teach them how to catheterize in case their catheter falls out. They need to know how to sort of emergency intubate and get the catheter back in. So the main complications of a continent ileostomy, the early complications are leak from any of the suture lines, the valve dying, a surgical site infection, a fistula, either between like the valve and the pouch, or the valve and the skin, or the pouch and the skin, pouchitis, and obstruction, which can happen with any operation. And late complications include, again, pouchitis, obstruction, then inability to intubate, incontinence, hernia, and fistula. So I'm going to go over some common K-pouch problems. So just, I recognize that most people watching this are not going to be making continent ileostomies. For the fellows who are listening, if you are at an institution where someone is doing continent ileostomies, I really encourage you to try to get that experience, even if you end up not constructing K pouches or Barnett pouches in the future. It is still a very useful bit of knowledge, because you may be the only person in a large geographic location that knows how to manage these problems. So I know that some of the attitudes around continent ileostomies is like, the only surgery I'm doing for a continent ileostomy is to take one out. So I've heard that before. I've definitely heard a lot of, and even my own partners sometimes say that, and I get it. I can see, I completely understand and see why some people are very opposed to continent ileostomies. That said, there are a lot of patients out there who still have them, and it will be less and less over time, but it is important to understand what the common problems are so that we can treat them appropriately. So one of the most common K-pouch problems is obstruction. So say you have a 65-year-old patient who had UC, had a Coke pouch done 35 years ago. This is a very common scenario that I see. Presents to the ED with nausea, vomiting, abdominal distension, no output for 12 hours. So what do we do? So first question is, are they able to intubate? So if they are able to intubate and just nothing's coming, they're able to intubate, and the catheter is going in the normal amount, then it's likely just a classic small bowel obstruction that's proximal to the K-pouch, and you'll see that on the CT scan. And you just manage that as usual. The K-pouch is not to blame, and just make sure that the patient continues to intubate and irrigate regularly. So hopefully when their bowel function does return, their pouch will start working again as well. If they need to go to the OR for, classic SBO, it doesn't, the K-pouch can stay, that there's nothing, really wrong with it. It's just bowel obstruction above the K-pouch. If they're not able to intubate, then the next question is, where is the area of resistance? So is it at the skin? Is it, they can get past the skin, but then they get to an area where they just can't navigate? Does it feel like there's a stricture? And those are just some, important things to figure out how to treat them. Generally, if the area of resistance is not right at the skin, then what you can do is you or a GI colleague can scope a catheter in and just leave the catheter in the pouch and let it drain, and then figure out what to do after that. If the area of resistance is at the skin, they've likely been having these issues for a while, where they're like, oh, like it's really tight. I've gone, I've decreased the caliber of the tube I've been using, and now I just can't get it in at all, And so in that case, then it just, it needs some dilation. And if the valve is fine, then it just, needs a little dilation, and then the catheter can be just placed in. Usually the patient is actually the best person to place it. So the other related issue is difficulty with intubation. So say you have a patient who had a care patch placed some years ago, and they come to your clinic with several months of increasing difficulty with intubation. So sometimes they're able to get it in, sometimes they're not able to get it in. They have to assume different positions. They have to lean over. They have to relax. They have to lay down. Like they're doing all these different things to try to get that catheter in. But they're most of the time able to get it in eventually. And this patient may have occasional episodes of incontinence. So how do we work this patient up? So again, the first question is, where's the location of the obstruction? Do they feel like it's at the skin, right at the skin, which is sort of an easier fix, or is it deeper inside? Do they feel like they're again like popping through a stenosis after they get past the skin, or do they feel like they're kind of trying to navigate their tube through a tortuous bit of small bowel? Then, assess the risk of persistent obstruction. Like if they're like, oh yeah, I can pretty much get in all the time, but I just have to work harder at it, versus someone who's like, yeah, I was having some trouble and now I totally can't do it and I haven't gotten a catheter in for a day. Then if it's the latter and you're worried about them having a persistent obstruction, they're not going to be able to intubate, then go ahead and scope a catheter in. And sometimes it's just like getting a Foley in it's just enough to, like a big Foley is enough to relieve them of the obstruction. If it's a stenosis at the skin level, again, it can be like an easier fix, like dilation or local revision. And then when you do the pouchoscopy for these patients, assess. One of the first things you do is, once you get past the skin, you want to assess the bowel and the subcutaneous portion, like before you get to the valve. Is it redundant? Often it's redundant and tortuous, and that's why they can't get that catheter in. And then you also want to assess the valve by looking, once you get into the pouch, you look back, you retroflex and you look back at the valve, and you want to see if that valve is short. So if you have a short valve, a short intra pouch valve, so it should be about it's never 6 centimeters when you look at them, but if it's a short valve and then you also have a tortuous bowel in the sub-Q, then we know that the valve likely slipped, right? And so it sort of slipped out of its intussusception. You also want to assess the valve for stenosis, like maybe there's a narrowing at the end. Sometimes there's a polyp there. So those are all the things that a pouchoscopy can tell you. Okay, another common K-pouch problem is incontinence. So say, a young person had a continent ileostomy 5 years ago, has had actually some incontinence from the very first month, but it's been getting worse over time. So again, question is, are they able to intubate? And usually they are, but sometimes it's the valve has slipped so much that there's so much tortuosity and the bowel's all crumpled up in the sub-Q that they're not able to intubate, and it's actually just functioning like a standard ileostomy, which can be really messy because it's usually a skin level stoma and it's in the wrong place for a standard ileostomy. The pouchoscopy is crucial for this. Again, assess the length of the valve and also assess the pouch mucosa. If you have someone who has like occasional incontinence, sometimes it's due to pouchitis. So I had a patient who had actually CMV of the pouch, and actually taking ganciclovir made his incontinence go away. So, and then if they're, having a lot of incontinence, then often their skin is really at risk. So it's important to consult a woundostomy nurse to help with pouching. So here is the pouchoscopy for people who have some issue with their continent ileostomy. So again, you want to retroflex and look at this valve. So this is like a pretty good looking valve. It's not 6 centimeters, certainly not as long as it was when it was first made, and they all flip a little bit like this, but this is a pretty good valve. If you see something like this, that's a pretty short valve. A lot of patients who have this actually are still continent, but it's just this has clearly slipped, and so they may have trouble intubating because what used to be like the 12 centimeters or that has doubled up is now hanging out in the sub-Q, so that can make it really difficult. So there's some things to evaluate, and then also evaluate the mucosa. If it's inflamed, you got to rule out Crohn's. Sometimes you might get consulted for someone who has blood in the stool, and you have to sort of work that out, figure out if it's pouchitis, it's Crohn's, or often it's an ulcer. So when they if they're putting their Medina catheter in and it's always hitting the opposite wall of the pouch, then that can create this chronic injury that can bleed. Sometimes it's a polyp as well. And so so this is an example of a patient, sort of similar scenario, able to intubate but has this incontinence associated with abdominal cramping. So the pouchoscopy can be really, and the biopsy can be critical in diagnosing pouchitis. So what are the indications for urgent K-pouch excision? So there are none. So really, it's very unlikely that you will get into a situation where someone urgently needs their K-pouch removed. If they have an obstruction or incontinence, whatever these are all things that can be managed in a more measured pace. And usually, especially for an obstruction involving the valve, then just scoping a catheter in can buy you some time and give the patient some time to think about what they want to do. If they want to live with a pouch with a catheter in, which is not really feasible. If they want to find a surgeon who can revise it for them, often they just need a lot of time to think about what they want to do. Okay, so the indications for revision are sort of what we talked about. So incontinence from a slipped valve, difficulty with intubation or obstruction. If they have a stenosis at the skin level, again, it can be a pretty easy fix that you don't have to have expertise in making continent ileostomies to do the revision. The key here is to, again, scope the pouch and pay attention to how much bowel there is in the sub-Q. If there's a lot of redundancy there, that's great, because what it means that you can sort of pull it up, like kind of like you pull up a sock, right? So it means that you can, free up the stoma from the skin and the sub-Q, and then just sort of pull up more bowel so that the skin isn't trying to grow together. That's usually what's happening there. And then sort of rare would be like a fistula that's causing trouble, would be an indication for revision. So for revising, if we're undertaking the revision of a K-pouch, the main discussion needs to happen pre-op. And the question is it possible? The first question is it possible? So assess the thickness of the subcutaneous layer. So the reason why this is important is that if you have someone with a thick subcutaneous abdominal wall, then you have a very long segment of bowel between the skin and the pouch. And that can sometimes be fine. But if the pouch is going to hang in the pelvis, then what can happen is that it's not a straight shot from the skin into the pouch. So it can kink, and it can just be difficult to get the catheter in. And sometimes, it can basically completely preclude the revision. Also, it's important to assess the bowel length. So figure out what their current output is, their nutritional status. If they're getting dehydrated, then, you may not want to commit to a revision. And then also figure out what their prior operations are. Often people have had prior revisions, and figure out how they were done. So if someone's already done some of the maneuvers that I'll talk about in a second, then it may make it very difficult for you to make a new valve, which is usually why people are getting revisions. And also, again, does the patient understand the risk? So you got to manage expectations. I always tell patients that there's a 50% chance of pouch excision and going back to a standard ileostomy. And a lot of patients will decide that what they're dealing with now is better to them than dealing with an external pouch. So I always tell patients that if their current situation is worse than having a standard ileostomy, then a revision makes sense. But if they wake up and they're going to be very, very disappointed with a standard ileostomy, and they're going to feel like they're in a worse situation, then a revision at this time is not for them. And it's a very individual decision. We've had patients who are completely incontinent, like their pouches are completely not working, and they would rather deal with that than to commit to having a standard ileostomy. And so, I don't ever force anyone to do anything in this situation. They sort of have to come to that decision for themselves, and they have to really feel like, what they're dealing with is worse than what they remember of a standard ileostomy. And it does require, a lot of counseling, repeated clinic visits to sort of discuss the situation, sometimes getting over some of the fear of an ileostomy. A lot of patients who had their continent ileostomies done 35 years ago are thinking about what life was like 35 years ago when they had an ileostomy, and maybe the pouches were not as good as they are now. And so, and a lot of people are very much, they very much feel and believe that the life that they have enjoyed and what they've been able to do with their careers and families is was not possible had they not had the continent ileostomy. So there's a lot there to get into. And so again, it's a very personal decision. And yeah, they have to really accept that an ileostomy is quite possible. So if you then decide that you want to revise a K pouch, then these are some of the things that one can do. So if you have this situation here where this is a slipped valve and the bowel is just hanging out here nice and free, then you could re-intussuscept the bowel. I have never been this lucky to see this happen and being able to just re-intussuscept it. It just has never worked out that way for me personally. But if this were to happen, that's a pretty easy fix. You just open the anterior wall of the pouch, you re-intussuscept it, you do everything that you would normally do to recreate that valve and secure it in place. But again, that's really rare. The more common scenario is that you want to be able to, so the valve, say, has slipped, it's sort of bungled up, you can't use that bowel anymore, or some issue with it, some fistula or some stenosis, so it needs to be excised. So basically you would remove this segment and just make it this enterotomy and just take the valve out and toss it. Then you're mobilizing the pouch and you're deciding at this point whether or not it will rotate. If the mesentery that it's on will rotate enough that it's not going to die and it's mobile enough, then you could do this 180 rotation and create a new valve using the upstream intestine to make the new valve. So you would use 12 centimeters or so, intussuscept it in, leave however much you need to get through the sub-Q, and then make the valve, rotate it, and then plug this upstream bowel into the location of the prior valve. So that's called a 180, rotation of the pouch. So the nice thing about this is that you save the pouch. You don't have to make a whole new pouch. I think it's pretty risky to make a whole new pouch because you could end up with a short gut situation. So I really try to save the pouch as much as we can. So those are the main two ways of revising a pouch. There are some other ways involving remove, like taking out a segment sort of farther up, but sort of same principles. So my final thoughts are, as a fellow, learn what you can, as much as you can. And, they don't come around, these cases don't come around very often. So when they do come around, definitely go in and take a look. Even if you're not the, primary person on the case, it's really very useful to see with your own eyes, what's going on in there. The other thing is, this is all about balancing quality of life and understanding the risks. So having that open communication, very frank discussion, counseling, taking the time to really make sure that you and the patient are on the same page is critical to everyone sort of having some peace and contentness about the outcome, no matter what the outcome ends up being. So thank you. And thank you for having me, and I'm happy to take any questions.
Well, thank you for all your kind of knowledge and wisdom, because I think that's more than most people know about kind of the K pouches, and we learned more in the last hour than most of us knew. So I think one of the questions that we were kind of discussing internally is, and you went over a lot of it, but when like the outside general surgeon from 2 or 3 hours away is trying to troubleshoot or transfer the patient or what have you, I think you gave a lot of really good advice as to like the questions and thought processes, but I'm curious if you have any other kind of additional advice about how to coach someone else on the phone through, the acute management of a complication.
Yeah, that's a great question. I think that so I think most commonly it is, and most, sort of the most urgent issue is obstruction, so first, I think that when they do the scan and someone's obstructed, they do the scan, they're like, what is that? What is that thing in there? And So the first thing is to figure out, is it the pouch that's the problem? Like, is it a huge pouch? And if it's a huge pouch, then you know that's probably the valve that's the problem. But if it's not a huge pouch, then it's probably something upstream, And so sort of coaching them about that, right? Like trying to figure out that decision tree. And if it is an obstruction at the pouch level, then just standard things like an NG tube. And if they're able to, if their GI person there is able to scope like even a Foley in, then that's super helpful. And if not, it's okay. Usually they can just get by with an NG tube and send them over to you, and then you or your GI person can get that catheter in. And then, with incontinence, so sometimes like if it's an incontinence issue, then it feels like, the patient usually is like very, very, can be very, very upset if it's the first time that they had incontinence, because they have associated their pouch with like being continent, so sometimes that worry can sort of transfer, so a lot of it is just sort of trying to assess if there's like an element of incontinence that's also obstruction, sometimes that it's an overflow type situation. Then I think those are, those are the main things to tease out.
Very helpful.
Yeah, definitely. I had a question. So, giving kind of weighing your options between an S and a J and coke pouch in patients who have pelvic irradiation, I would assume that you would probably think that their bowel function with any of those type of, natural drilling pouches would be pretty poor. So, would you probably recommend a continent ileostomy at that point?
Yeah, I think if they've had pelvic radiation, if their sphincter function's good, and they have like, if you had to say a case of like someone with FAP or ulcerative colitis who had rectal cancer, say, right? If their sphincter function's good and their small bowel wasn't irradiated, then I think a pelvic pouch is still okay. But again, like, you know, if they decide not to go with a pelvic pouch, then we still have to assess for, whether there was radiation damage to the small bowel. Usually there isn't, I think those are really important considerations for sure. But I think, just assessing their sphincter function is probably good.
Is there a special K-pouch diet that you have people on that kind of keeps the consistency of the effluent pretty liquidy,
Yeah,
or
that's a good question. So I don't really. I mean, I feel like a lot of my patients eat like they eat pretty much whatever they want, and some of them will just say like there's certain foods that they know they can't eat, or they have to chew really well. Some patients are like, really good about irrigating and making sure that everything gets emptied. Others, either are not irrigating as much, or the configuration of the pouch is such that like gravity is kind of fighting against them, so the pouch is kind of hanging in the pelvis, so it's hard to like get it all out. And so when I've scoped them before, they've had like a lot of stool in there, and sometimes it can cause like this small bowel intestinal overgrowth too. So for those patients, I try to, just that you got to irrigate more and that sort of thing. But yeah, it's usually, it doesn't seem like they have to eat that much differently than someone with the standard ileostomy.
This is more of a social question, but do you know, are there like Facebook groups or support groups for
Yes,
people that have
I
K-pouches?
yes. I don't know, and I haven't looked, but I know there must be, because that's how people find me, I think. So, and I've noticed like there's been a couple surgeons who like sort of the original K pouch and BCI creators that have retired recently. And now I'm getting a lot of their patients, just to establish care and be like, hey, I'm, coming from Southern California or Oregon because my surgeon has retired, and I just, want to make sure that I have someone to talk to if something goes wrong. So yes, I am sure that there are some groups.
Awesome. And then from the surgeon side, do you feel like there's like a community that kind of exists like on a Facebook or a WhatsApp as well?
We don't have like, I mean, I'm not part of it, but I do know of, there's like, I know of 5 other surgeons. I'm sure there's more, but I know of 5 surgeons in the country who do continent ileostomies. And, so yeah, I've like, you know, we've texted each other about just the stapler issue. And some of them have had success with like taking the pin out on the transverse stapler, but I just like I've wasted a lot of staplers trying to figure out how to make it work without scissoring. But anyway, so we've all sort of commiserated about that.
Yeah, good to have a community to chat with.
For sure. Yeah, and I'm hoping that there's more, young people who adopt the skill so it doesn't completely die out. But yeah, I do recognize that it's probably eventually gonna, not be done anymore.
What stitch configuration do you use? Like earlier you mentioned that if a stapler wasn't available, you used a permanent stitch, but do you do like a horizontal mattress to prevent tearing?
Yeah. Yes, I've used like a mattress suture with Proline. It's not great, but yeah, I felt like all the absorbable sutures would just for sure would slip. So, or it's actually with silk. Actually, I think I did it with silk, and that pouch is still working. So that's a good thing.
Awesome. I think that's most of our questions for tonight. So
Okay,
I wanted to
great.
thank you for your time, and it was very educational. So thank you for contributing.
Well, thank you for having me.